We'll move on to our next session, which is a panel discussion on interventions in pain rehabilitation. For this session, I'd like to invite on stage our moderator, Dr. Piyali Mondal Basak ma'am, consultant pain and rehabilitation physician, currently attached with ESI Maniktala Hospital. And the panelists for this session are Dr. Amitava Biswas, consultant spine surgeon, Kothari Medical Center, Dr. Arghya Mukherjee, anesthesiologist and pain physician, Manipal Medica, Dr. Mohit Kataruka, associate professor, Department of PMR, AIMS Kalyani, and Dr. Tanvir Ahmed, PDT Neurology on Trainee Reserve and assistant professor, IPG MER and SSKM Hospital. I'd like to invite the panelists on stage and the moderator.
Good afternoon, everyone. Today we are going to talk about intervention in pain rehabilitation. Before that, I am honored to invite the eminent panelist. One by one, I will introduce. First, Dr. Arghya Mukherjee. He is currently in Manipal Hospital as a HOD of Onco Anesthesia. Dr. Amitava Biswas. He is a neurosurgeon and attached to ESI Hospital along with Kothari Medical Center. Dr. Mohit Kataruka. He is a HOD of PMR in AIMS Kalyani. And Dr. Tanvir Ahmed is an associate professor in SSKM Hospital in PMR. Low back pain is a common painful condition affecting the lower part of the spine involving the muscles, nerves or bones of the back. A large proportion of the adults will experience low back pain at some point in their lives. Prevalence noted from 96.2% to 92% in India. It is caused by injury to a muscle due to the strain or the ligament due to the sprain, or other common causes include improper lifting, poor posture, lack of regular exercises, a fractured vertebra or a fractured disc, or the arthritis. This is a patient summary. A 45-year-old man has a textile factory job presented in OPD with a history of low back pain for 1 year. He is diabetic type 2 and he climbs up to second floor by stairs every day. His pain is radiating to both leg up to the great toe. Pain is electric shock like and history of neurogenic claudication after 7 minutes of walking. There has tenderness over the bilateral paravertebral area around the lumbar spine. His bladder and bowel sensation is normal. Mild weakness in EHL, extension hallucis longus, bilaterally, and SLRT test is positive in both sides. Patient is already on neuropathic medicines and NSAIDs SOS basis. And the basic spine exercises has been advised. Now, patient is very anxious and depressed. His NRS score is 7/10. X-ray of the spine showed degenerative changes with the disc space loss, and MRI revealed L4, L5 and L5S1 diameter is 8.5 and 8 millimeter subsequently, and NCV revealed L5S1 bilateral radiculopathy. Now I am going to the questions. So my first question to Dr. Tanvir Ahmed, that what may be the cause of suffering of this patient according to you?
Can we go back to the summary slide, please?
Yeah.
So to analyze the suffering of the patient, we will look to the anatomical substrate which might cause these symptoms. So he is a 45-year-old man, so he is already entered the age group of early degenerative spine disease, and he is also a type 2 diabetic. So this type 2 diabetes, is there any relationship of this lumbosacral pain? So commonly in type 2 diabetes we see that The commonest symptom is that diabetic polyneuropathy, it is sensory motor neuropathy, which is distal predominant, bilaterally symmetrical. So this profile does not match with the patient. The second uncommon differential diagnosis is that diabetic lumbar plexopathy or Bruns-Garland syndrome, which might tally with this patient. So we have to keep this differential in mind. The second is the type of the pain. The pain is shooting radicular pain. So this origin of the shooting radicular pain is most probably in the nerve roots, because if the lateral spinothalamic or the posterior sensory symptoms of the spinal cord are affected, we will expect a funicular pain. So the nature of the pain is not a funicular pain. And the additive factor is that claudication, which is appearing after 7 minutes of walking. So I will narrow down to two substrates from the history. First is the exiting nerve root radicals, and the second is the lumbar spinal canal stenosis. So if we go to the investigative findings and the examination findings, SLR is positive, which is in favor of the radiculopathy. And in the investigative findings,
and he has neurogenic claudication also.
So lumbar canal stenosis, that is the second differential from history we are getting. And the point which we are not getting from the MRI is that the AP diameter has been mentioned, but what is the condition of the exiting nerve roots? How are they?
How much I remember, it is a case, the patient has a L5 and S1 lateral neuroforaminal, both the side, L5, S1, there is a both the side neuroforaminal compression, and the L4, I think what I remember, lateral neuroforaminal compression is there.
So I would suspect that now this patient is having two pathologies. One pathology which is contributing to the sensory symptoms, radicular pain, that is the exiting nerve roots, and the second is the AP diameter of the lumbar canal stenosis.
Yes. So apart Dr. Arghya Mukherjee, I have a question for you. Apart from these diagnoses or the pain generator, causes of pain generator, do you think whatever the diagnosis has been mentioned, like X-ray, MRI, clinical examination, NCV, do you think anything apart from this is required?
Good afternoon, everyone. First of all, thank you, organizer, for giving me the opportunity. Yeah, here the differential diagnosis are pretty almost clear, that degenerative lumbar disease is disc disease is there, as well as there is radiculopathy. So and the other investigations like MRI and then nerve conduction tests and the symptoms like mild extensor hallucis longus paralysis is a corroborative to that. But is this the pain is predominantly discogenic or the pain is predominantly radicular? That is the thing we have to take care, because when it comes to relief of that pain, for that we can go for diagnostic discography test, and here we have two levels, so we have to go for at least 3 levels. That means one control disc and 2 other affected disc. But in reality, diagnostic discography is rare, taking the considerations with the risk involved in it. But yes, diagnostic discography with the dye test can give some edge over it for the pain generator.
If you prefer diagnostic discography, which dye do you prefer?
Usually nowadays the most common
because
used
patient
dye
is diabetic.
Yeah, but most commonly used dye is iohexol. That is the omnipeg dye, and mostly 320 or 350 is the concentration we use. And as because these dye are less harmful, ionized, this is a non-ionized kind of dye. Ionized kind of dye is nowadays not being used.
Yes. Do you think that facet joint block or the paravertebral trigger point injection can be added to the diagnostic, like for diagnostic block as a?
See, whenever there is a degenerative disc disease, there will be, with a low back pain, there will be some spasm in the muscles as well in those areas. But even in MRI, there will be some clue regarding the facet joints, how the conditions of the facet joints are in the MRI. Unfortunately, here we cannot see that.
Yes.
But with this acute condition, even all those doing all those tests in a same setup will be difficult.
Okay. So my next question to Dr. Amitava Biswas: what are the leg flag signs are to be ruled out?
Thanks for the invite. Just one small correction. I am an orthopedic surgeon, orthopedic spine surgeon, not a neurosurgeon,
Okay.
who have never done orthopedics. So the thing is, in this patient, one of the, I would say, the red flags and the yellow flags of any spine pathology is revealed from the history and the clinical examination itself. Just overall view from the history itself, very important is when we are dealing with extremes of age, less than 18 years and more than 60 years, any back pain should be seriously considered, especially in a child complaining of severe back pain, disturbing with the sleep, with night cries, and in patients of possibly this age group or a little more than 60. We should evaluate back pain. So these are the most important groups where we have to evaluate. The history is very important, especially the drug history, whether the patient has chronic COPD, whether the patient has an arthritic disorder. Always at the back end of our mind, we should know, we should suspect chronic steroid intake, or even aspirin or antiplatelets, where acute back pain and even claudication can be because of epidural hematoma. Or sometimes in my practice, I see many times ligamentum flavum hematoma. Just yesterday I operated a case where the ligamentum flavum was black instead of yellow. So that patient was on chronic antiplatelets. So the drug history is very, very important. History of trauma, of course, not of course relevant to this patient. History of constitutional symptoms, more than 60, acute loss of weight, appetite, and all those things will generally come in the red flags. Now these are the red flags, I would say, symptoms. The signs, of course, the most important is the neurology. Neurology, the bladder bowel symptoms. A patient who has got bladder bowel symptom, perianal anesthesia, weakness, and documented sensory and motor weakness are obviously the red flags in a patient.
In a EHL, how much EHL weakness you can think it is a red flag sign?
To me, it is not a red flag, because you see, most of these patients of lower lumbar pathology will have mild EHL weakness.
No, if it is more than less than 1 or like that.
Yes, then it is quite significant. But 3 or I would say at least if it is 3, I won't. Again, coming back, it's not just one component, as Dr. Tanvir said, and I think your Dr. Arghya said. So this is all a multimodal assessment. Where is the pain generator? Now I would just, in relation to this case, I will just point a little bit confusion. The patient has bilateral electric shock like symptom.
Yes.
This is very rare, I would say. Very, very rare. So in my practice last 20 years, getting a patient of bilateral radiculopathy is possibly very rare thing. Bilateral radiculopathy.
Generally we can get.
Generally they have bilateral claudication. So but bilateral electric current like symptoms can definitely happen. Possibly there is a large disc herniation.
Yes.
If it's a cauda equina kind of picture that we are getting, then we get a bilateral electric current. So in that case, I would be more thinking in terms of course we don't have the scans here, so I would think in terms of cauda equina compression.
Yes, but I mentioned that bowel and bladder sensation is normal.
Yeah, that's a confusion.
But if it is not there, then it is a red flag.
Yes, yes, yes.
So what kind of conservative management, my question is to Dr. Mohit Kataruka, what kind of conservative management in terms of physical therapy and then electrotherapy, exercise, medicines, any other medicines if you want to add, or lifestyle modification, would you suggest to help this patient?
Yeah, when a patient is coming acute pain, we generally start with pain medicine like NSAID with muscle relaxants, and in modalities, different modalities are can be applied like short wave diathermy or hot magnet. These are deep heat modalities. They helps in muscle relaxant and they reduce the pain component to some extent. And if the patient has a radiculopathy like this case, we can apply TENS or IFT, and that's actually helps a lot and reduces the pain medicine also. And apart from that, we can add pregabalin or gabapentin, that also helps in reducing the radicular pains. And most important thing is the lifestyle modifications, because the patients often get chronic pains and recurrent episodes. So changes in this posture, not to bend forward, or during work related ergonomic modifications, these are very, very essential for this type of patients.
Because the patient is also has a, I don't know, textile factory job, maybe some desk job along with some,
for desk job,
maybe not desk job also.
yeah, like if he is a heavy worker like labor, so ask him not to bend forward, or try to modification his work to reduce the stress strain in the back. And if he is a desk job, then proper maintaining his desk with proper labeling of his computer, like that way we can do the
An ergonomic chair.
Yes, they are very, very essential for to prevent this recurrent episodes.
Okay. My next question is Dr. Tanvir Ahmed. Is the complete bed rest or the lumbosacral bracing for a long time, more than 1 month, is it advisable in this case?
Considering this case, this patient is probably suffering from a chronic low back pain. So in this patient, I will not consider complete bed rest. But there are some situations that there might be acute exacerbation of these pains. So do we advise complete bed rest? The recent guidelines, all the European Spine Society guidelines and various other guidelines, they advise against this. And there are multifarious factors. If you give complete bed rest, then there is deconditioning of the body, and this deconditioning will be more in the spinal, paravertebral muscles. There will be muscle loss, and this cycle will go and continue. And the second is if you suddenly give complete bed rest to an active person, there is a component of depression which will come in, and this depression will lead to this is a peripheral pain, and this pain will have central sensitization, and this will then convert to a chronic pain. So we have to prevent this from the way. What we can do, we can advise some activity modification, some amount of activity limitation only, just as discussed by my previous speaker, such as bending forward, etc. Lifting weights. Even if lifting weights, then it should be close to the axis of the body. These things we can advise.
That
but
means the complete bed rest or the lumbosacral bracing for a long time is not advisable at all. Next question to Dr. Arghya Mukherjee. Is any particular pain procedure, do you think, which can help this patient? And how frequently the intervention can be done?
The patient is suffering for 1 year, okay? So already there is set in chronic pain, and he might be having many medications, many things. So interventional procedures can be done. Only problem is from the MRI, as we have discussed, that is it a central protrusion or prolapse, or even sequestration, that is not clear to us.
Yes.
So recommendation is for acute pain relief is epidural steroid injection.
Yes.
Again, and now the thing is, there is the canal diameter is borderline 8.5. So even it is not clear the pain generator, which level pain generator is there. So the commonly done epidural steroid injection is a transforaminal kind of approach we commonly do.
But here the radicular pain is both the side.
Yeah, so that's why maybe an intralaminar single shot epidural kind of injection would have been better, or single shot approach, or even otherwise you have to go bilateral 4 level
bilateral transforaminal.
injection.
Or caudal also can be helpful?
Yes, caudal can be helpful because it is a L5S1 and L4 L5. It can be given.
So, when to give, like how early you can plan for the intervention? After seeing the patient, it came to your OPD and already giving you more than 1 year pain. So, when you start think of intervention, like within some week, or you will take some time?
No, see, we are already late here because already 1 year and this thing. So, patient is already having medications probably for many months have passed. So, in my OPD, if I see these patients, I will directly approach for these kinds of epidural. I will offer an epidural with the thing that in background that we do not know, still do not know the pain generator now with this scenario. So, this discography not being done, so we do not know even the pain generator, but even the midline epidural will anyway cause pain relief.
So you will start, like you will advise for the intervention as early as possible.
As possible, yes.
So you know that how much the intervention stays for how long. So if you want to repeat, how you counsel the patient and when you should repeat?
See, actually, the epidural steroid, there are controversy regarding the particulate, non-particulate steroid nowadays in foreign countries. They are not allowing even particulate in lumbar and other areas, but we still are using particulate steroid with for prolongation of analgesic activity. But even in these kinds of scenario, as the other speakers also, we are apprehensive that this should be a big disc.
But if you
so
do,
the
like
suppose effect of steroid will not going to stay long, not
so
more than.
If you want to repeat, how you counsel that patient may come with the same type of pain or the lesser type of pain, and you may need another sort of interventions. So how frequently you can ask that patient and how you counsel the patient?
Yeah, I am coming to that. So I anticipate that 6 week to 8 week may be the single injection effect. So not more than that in this particular case, this might happen. So I cannot say a patient that every 8 weeks or even every 2 months you come and take an injection. It is not like that. So 1 or 2 repeated injection for my practice, it is maximum, and definitely you have to go for definitive procedure. May it be endoscopic discectomy, may it be open discectomy, whatever the RFA procedures, definitive procedures we have to do that.
So what dose of steroid you prefer during the transforaminal and caudal or interlaminar?
See, even the lifetime dose or the 3 years dose, they say maximum.
Dexamethasone you prefer?
No, we are using this dipomedrol is nowadays not available. It is not being produced anymore. So triamcinolone is the only
drug. So it is a particulate steroid.
Particulate steroid we are still using, and the maximum in this case we can given the body weight is not there. Maximum we can given up to 60 milligram to 80 milligram in this case. So 2 triamcinolone
can be given in one
sitting
session. Okay.
One session.
Is there any? My next question is to Dr. Amitava. No, 1 minute. Yeah, my Amitava Biswas. Can you think of any kind of surgery and which is preferable in this case? Less invasive endoscopic procedure or the spinal fixation surgery? There is no history of trauma.
This patient, of course, has got pain as well as claudication, and in our spine world, although if you have a general perception of the canal diameter, I would say that is the biggest fallacy. I never look at the canal diameter because it has been extensively proven that the midline canal diameter has got no correlation with the symptoms, neither the outcome of the surgery. So I never see the report, especially the canal diameter never comes my picture. But again, most of my patients come to me showing me the canal diameter. Somebody has referred because...
Even I have seen in my OPD also less than 7.
Less than 7, you have to go and get it operated. So the first thing, I educate my patient, that is most important. canal diameter is not at all important, because we know the maximum symptoms in a spinal canal comes from the foramen. So I look at the foramen, right, left, central, paracentral, means mainly the subarticular part, foraminal and extraforaminal part. So the MRI scan is definitely important. This patient I cannot plan without seeing the MRI, without touching and seeing the patient, clinically examine the patient. But whatever I can get in this patient is, whatever is the canal diameter, the patient's neurogenic, the claudication distance less than 7 minutes. That is possibly the most important factor in this patient too, rather than the
His
pain.
diameter is 8. 8
No,
or
no,
8.5.
you said can you,
Yes, yes.
the claudication distance, this is most important in this patient, because I have not seen this patient. Whatever is the EHL, whatever is the canal diameter, whatever is the pain status, of course pain management can be done, bilateral, I think ESI's work, but the claudication less than 7 minutes in a 45-year-old male is very much concerning to me. So of course he has lateral canal stenosis to me.
Yes, yes.
So
that is
there is no doubt about that, irrespective of the mid-sagittal 8 and 8.5. So in this sort of scenario, the first our approach is clinico-radiological and maybe a block correlation, because now we have extended into even a block correlation, not just a clinico-radiological. Where is the pain generator? So if I can get a convincing picture that it is due to lateral canal stenosis, foraminal
Yes.
or extraforaminal, causing him
Yes.
severe neurogenic claudication distance. So
We are running short of time, so please.
I'll just wrap up. So here first thing that I have to rule is the instability. Whether there is a spinal instability or not by the dynamic X-rays. If there is no instability, my first choice will be endoscopic decompression. Because in last 8 to 9 years, I have slowly shifted to endoscopy, and considering 45 years, I know that there will be some amount of stenosis. And because of bilateral symptoms, I will go for interlaminar PSLD approach, bilateral decompression. Maybe both the levels or one level.
But you preferred the endoscopic procedure?
Possibly, yes. I can imagine the MRI, and if it is LCS bilateral 4551, I will try to do the more severe one endoscopically in the interlaminar approach, not the transforaminal approach,
Okay.
because he has got bilateral symptoms.
Yes. So when we will plan for the surgery, is there any specific indications? Like any red flag sign?
This patient, I don't suppose there is enough red flag signs, because he doesn't have that gross neurology, not dense neurology, and he doesn't have bladder bowel symptoms. But yes, here the patient has to buy the surgery from me, because I need to follow up this patient and tell him the pros and cons of getting his neural decompression done to get rid of the claudicating symptoms. Of course, with a fair trial of conservative management and blocks.
And also the ESI, like after fair trial of ESI?
Yes. He, after trial of ESI, medications as PBS system speaker store. So after everything gets exhausted, and then I give the option that decompression will improve your quality of life, and you'll get a better walking distance.
My next question is, Dr. Arghya Mukherjee, is the regenerative therapy in the disc will be helpful? If there is a, you said that this bulge are there, if yes, then what level of evidence is this?
It's a very controversial, because in many a country regenerative therapy in the disc is completely banned and completely, but still work is going on.
Yes.
Especially stem cells, many practitioners, they are putting stem cells with the hope that they will regenerate and increase the disc level, but believe me, this is still in level 1
Some
or 2
pain physician also
experimental.
started giving PRP also in
Forget
the
about
specific-
PRP in spine. I don't believe in PRP in spine.
Dr. Amitava Biswas, do you have anything to say about it?
2000 till 2018, in my first endoscopy days, I started endoscopy in late 2016, and 2016 to possibly 2018 end, I used to use that PRF after doing my endoscopic discectomy
So you
and annuloplasty. So,
No,
as
no,
to
no. I was
in-
talking about the regenerative therapy, like PRP. Do you know anything about in
Oh,
giving
no,
the
no,
disc,
I don't
or
have much
the
of
disc
experience.
herniation or the disc prolapse?
No, not at all. I don't try
Yeah.
those.
So there is
Yes.
no level of evidence yet
Yes,
to be
yes, yes.
came out to proven the fact. Okay. So my next question is, Dr. Tanvir Ahmed, how to address the patient's psychological issue? As you can see in the case summary, patient is very depressed and anxious about his pain.
So any chronic pain. So chronic pain and depression, they are like twins. They go side by side, and one feeds the other. So most of the conventional treatment, they address the pain. But what about the depression side? And this depression comes from many aspects. The patient is having pain, that is the cause of depression. He is having loss of function, the normal, his day-to-day or ADL he is losing. That will give rise to the depression. So we have to address this depression from the very early part. And apart from giving the neuropathic medications, we might think about some SSRIs or SNRIs that had to be added. And this is actually if you think about the pain pathway from the lateral spinothalamic tract, thalamus, and then it goes to the primary somatosensory cortex, but it also goes to the cingulate cortex and the anterior thalamus and these insular cortex. So the emotion of pain, you had a very painful surgery. The thought of that painful surgery about 10 years back is going to bring tears to your eyes now. So this chronic pain and this emotional connect are present, and they have to be addressed by medications. And there is another, that mindfulness approach.
Yes.
So mindfulness cognitive therapy,
It's a kind of
some-
meditation or
some even
psychological
meditation,
counseling.
and they usually work by the descending endogenous opioid pathways, which will help to deter these psychological issues.
Thank you. Thank you for everything. Thank you for answering so nicely. So now we will conclude the session, that identifying the pain, actual pain generator is very necessary, and multidisciplinary treatment approach are the key rule for the low back pain management. We should address the psychological issues as well for the complete pain relief. Early intervention is advisable, and exercise and lifestyle modification, not to decrease the pain, but has to be incorporated in life for the lifelong. Thank you.
Just
Thank you for patience hearing, and
just I want to add one thing. What Dr. Amitava was saying, there is a significant role of RFA.
yes,
Different types of RFA we did not discuss here because of the time constraint, particularly discogenic pain. There are several types of RFA
yes,
can be done
RFA for the
in
medial nerve
disco-
branch and
and-
all these things we can also done. Thank you for the opportunity to give me to moderate this session. Thank you for the patience hearing. Thank you.
Thank you to our esteemed panelists.